I'm Dr. Jeff Lawrence, and I'm an orthopedic surgeon for Gundersen Health here at the Viroqua Center for Orthopedic Surgery. The great thing about hip replacement is that it tends to be very predictable and reproducible for most patients. Outcome studies show excellent patient overall satisfaction, and I would be very optimistic that we can improve your quality of life with a hip replacement. To perform this surgery, we use a spinal anesthesia about 98% of the time, and this numbs your body from the waist down. You will have an IV in your arm, and if you prefer, we can make you as sleepy as you want to be. If you would like, you can stay awake and watch your procedure on a high-definition TV monitor. You can ask me questions, and we can discuss the procedure while we are operating. People that do watch tend to find it quite fascinating, and they feel that this really adds to their understanding and to their surgical experience. About half of our patients stay awake, and the other half choose to be asleep. A very small percentage of our patients have a general anesthesia for certain health issues or a significant history of spine surgery. We make an incision that extends along the butt cheek. Most of the time, we use a minimally invasive incision that measures about 4 inches. We may need to make it a bit bigger if we need better exposure. This animation shows an arthritic acetabulum, or the hip socket. This is shaped to a perfect hemisphere to match the size of the implant by a reamer that will remove any remaining cartilage and bone irregularities. A metal shell is placed into the prepared socket with a very precise fit. Screws can be drilled through this shell to add more secure fixation. A plastic liner locks into the metal shell. The back side of the shell has a porous coating that allows bone to grow into the shell to provide long-term stability. On the thigh bone, or femur, the ball is removed with a saw. The bone is prepared for the new implant, and a metal stem is precisely fit into the canal. This can be secured with porous coating on the stem and bone ingrowth, or rarely with bone cement. A metal or a ceramic ball is placed on the stem, and the ball is reduced into the plastic liner. As the hip moves, it will now painlessly rotate metal or ceramic against plastic. The pain from movement of bone on bone has been eliminated. Frequently, arthritis can cause shortening of the involved leg. As the cartilage and bone wear, the leg length will be affected. We use a computer-assisted navigation system to help restore your anatomy as accurately as possible. This is similar to a GPS system that one would use for directions, but this is obviously for surgeons. We place 2 pins directly into the pelvis here, which is along the front of your belt line. We then attach ceramic balls to the end of these pins. The pins come out at the end of the procedure. The location of these balls is read by a camera device that feeds into the computer. Another set of markers is attached with adhesive to the outside of the knee. A screw is placed into the outside of the bone as a predictable landmark. A pointer with ceramic markers is placed into the screw, and the computer records the relationship of the screw to the other markers. This will store the starting position of your leg length as well as the distance of your bone from the center of your pelvis. Before we put the real implants in place, we assemble temporary implants that look just like the real implants, but will give us a sense of how well we have restored your anatomy. We use the recorded point as a reference, and the computer will tell us whether your leg is longer or shorter, wider or more narrow. The implant is modular and has a stem and a neck portion. This gives us considerable flexibility to change the length or width of the implant if needed. We can also change the neck angle. Once we have matched the implant and computer information with your anatomy, we then place the real implants. There exists an individualized relationship between our spine and our pelvis. Depending on how stiff our hip or spine may be, the position of the socket can change dramatically as we sit and stand. It's imperative for surgeons to understand this relationship because some patients may rotate their pelvis into a position that allows for impingement of the implants or bone and can lever the hip out of the socket and create a dislocation. To minimize this risk, we order x-rays of your spine standing, sitting and flex forward, standing and lifting the opposite leg, and a CT scan of your pelvis, spine, and legs. This information is sent to a team of engineers in Australia that reconstruct this information in a computer program that allows us to see how your hip and spine move before we do the surgery. We can virtually implant a hip replacement on the computer screen and move the implants into a position that will match leg lengths and minimize any risk of impingement and subsequent dislocation. This is the dashboard we received to analyze the spine and hip relationship and allows us to modify the implant position. This page tells us the change in pelvic tilt with activity, starting leg length and width, spine stiffness, bone density, and virtual cup and stem position. A virtual video of the hip motion will show us impingement in this example. Changing the cup position eliminates that impingement. Once the plan is created, we need a system to deliver this accurately in the operating room. A custom cutting guide is created to match our plan for the femoral neck cut. Molds of your socket are also made with an insert that we place into your own hip during surgery. There is a hole in the model that allows us to place a laser device that directs a beam on the ceiling. A second laser is placed on the pelvic navigation pins to store this location. This point is then used as a marker for when we place the actual implant, so that we can reproduce our plan from the computer. We inject the hip with a long-acting pain medication at the end of the procedure. With the spinal, the soft tissue injection, and oral pain medication, we do a very good job of controlling your pain. Frequently, patients feel that they had more pain living with their arthritic hip than we create with the surgical procedure. However, there is no way that we can completely eliminate the pain. We start with a strong pain medication, and we then can modify the dose or the drug as necessary. We have many options, and we will work very hard to find the medication combination that is right for you. It takes us about an hour to do this operation. All stitches are placed below the skin, and the wound is sealed with medical-grade crazy glue. This allows you to shower within a few days. We'll have you out of bed the day of surgery. Discharge home will be that same day or the next day for most patients. That will be determined based on your overall health and activity level. Before you go home, you will need to be independent enough that you can get in and out of bed by yourself, get to the toilet, and climb stairs. For patients that have difficulty reaching that level of independence, short nursing home stay may be recommended. For patients going home, we recommend that someone be with you around the clock for at least the first week. Physical therapy will give you a stretching and strengthening program for you to do at home for the first 6 weeks. After discharge home, you will have an outpatient physical therapy evaluation at 2 weeks to see how you're progressing. If you are on schedule, we will have you continue with the home program. If you are in need of more attention, we may have you go to therapy more regularly as an outpatient. At 6 weeks, physical therapy will advance you to what we call our Phase 2 program. This is a more advanced program of stretching and strengthening. Most patients will again be given a home program, but patients needing more attention will be scheduled for outpatient therapy. We have previously discussed dislocation. Physical therapy will work with you to help you avoid certain positions for the first 6 weeks to allow scar tissue to build up around the joint to help stabilize it and to minimize the likelihood of this happening. We lift all but 2 of the physical therapy precautions at 6 weeks. 2 restrictions will remain forever. The most risky position is when you bend and twist. From a sitting position, bending between your legs or directly over your operated leg is fair game. You can bring your leg up to your chest as far as you want. Rotating your leg into a figure of 4 position is safe, but many patients are not able to cross their operated leg over the opposite knee. Once you get outside of the plane of your hip, knee, and ankle, this begins to become relatively unsafe. If you were to bend and twist, such as this, the risk of dislocation increases. From a standing position, the rule is the same. Bending over the non-operative leg and trailing the operative leg behind is always the safest strategy. When bending with both feet on the ground, which is completely okay to do, you are safest with your legs spread further apart. Bending down the middle should be a safe position. If you bend and twist, such as plugging in a vacuum cleaner or throwing wood, the hip can potentially dislocate out the back. As long as you keep things in front of you, it is unlikely that you will ever have a problem. Driving is not advised for 4 to 6 weeks for a right hip. You need to have enough strength to slam on the brakes and be safe. For the left hip, You need to be off your narcotic pain medication so that you are not driving under the influence and can drive anytime you felt comfortable. If you had a pain pill within 4 hours, you should not be driving a vehicle. Risks, percentage-wise, are quite low, but if they occur, they can be significant. The risk of infection is 1 to 2% nationally, but our infection rate has ranged from 0 to 0.75% in a given year. We give antibiotics before and after the procedure. We use spacesuits with a hood so that our hair and skin do not flake off into the surgical field, and we have special airflow that blows air away from the patient and not directly on you. Wound healing can be very rarely a problem. Injury to nerves or blood vessels are very unlikely and are 0.58% and 0.1% respectively. Fracture is also very unlikely. Blood clots can develop in your legs, and if they travel to your lungs, can be serious. We put you on a medication to minimize that risk. The medication can be an oral blood thinner like Coumadin, Eliquis, or Xarelto, but for most patients we use a baby aspirin twice daily. This choice depends on your medical history and your risk profile. The use of spinal anesthesia decreases this risk, as does an inflatable device on your feet that helps to push the blood back up through your veins, and the fact that we get you up and out of bed so quickly. The risk of blood clots without treatment can be as high as 47 to 64%. Even with treatment, the risk can be up to 6%. The real risk is that the clots move and go to your lungs, which can be life-threatening. The risk is less than 0.01%. The risk of a bleeding complication from the blood thinner is 1.2%. Leg length can rarely be an issue. We use the computer navigation device that we previously described so that we are typically extremely good at getting your leg lengths exactly the same. But the longer the leg is, the more stable and the less likely to dislocate it will be. You would rather have a leg that is a bit longer but stable than a leg that is exactly the same length, but every time that you bend over it dislocates. If we need to lengthen your leg, it is usually such a small amount that patients can't really detect a difference. Rarely, we may need to lengthen the leg enough that you can tell the difference. The worst scenario will be that you will need to put a lift under the non-operative shoe. Again, this is an extremely rare event. We use only implants that have performed well. I think that it is reasonable to expect at least 20 years out of this hip, but it may be less than that, particularly depending on your weight and activity. The 20-year survivorship of total hips is about 99% for the femur and 93% for the socket, meaning that these implants are still in the patient and functioning at 20 years. We don't recommend that you run or jump with the new implants, but can pretty much do anything else that you want within the dislocation precautions that I have discussed. The more stress that you put on the implants, the faster that it'll wear out. It is extremely rare for patients to lose enough blood to require transfusion. For most patients, we can use a drug called tranexamic acid, which significantly reduces blood loss. If you were to lose enough blood that you needed a transfusion, the blood bank blood is screened for AIDS and hepatitis. The risk of disease transmission is exceptionally low, but not zero. The risk of AIDS is 1 in 200,000 to 1 in 800,000. The risk of hepatitis B is 1 in 200,000, and the risk of hepatitis C is 1 in 3,000 to 1 in 5,000. Finally, there is a mortality rate of about 0.07%. We have a family physician from Viroqua look after your heart and lungs and general health before we proceed with surgery. That physician will also be available after surgery to follow you if necessary. Other unexpected complications can occur that have not been listed. These are extremely rare and have a likelihood of less than 1%. We are honored that you have chosen us to care for your hip problem, and we are proud of our ability to provide you with this leading-edge technology here in Viroqua. Thank you for listening.